Good morning and welcome to this presentation on the Eastern Cape Rural Health Onboarding Program. It's being presented at Rural Health Conference 2021 in September. My name is Dr. Madeleine Muller. I'm a family physician and senior lecturer at Walter SisuluUniversity, currently working at Cecilia Makiwane Regional Hospital out in Mdantsane in the Eastern Cape. For RuDASA, I'm also carrying the mentoring portfolio, and this is one of part of our strategic plan has been the development of this Rural Health Onboarding Program. So a little bit of background on this project we undertook earlier this year. Now every single year we have new groups of doctors, community service officers, but also other doctors that join district hospital-based hospitals all over the Eastern Cape. And we've got quite a high turnover of doctors in the Eastern Cape. So there's always an influx of either foreign doctors or doctors moving from regional hospitals to rural facilities. And what we have found is that a regional hospital training in the 2 years internship is not always able to really prepare the young doctor for arriving at a rural facility. Now that we have the 6 months rotation to family medicine, that will certainly help. But quite often the medicine is very specialized and doesn't really prepare the doctor for that setting going off into rural health care. So already, we've been discussing it for many years, but in the Rural Health Conference in 2019, myself and Jenny Nash was again really saying, no, we need to now do something about this. We need a proper, regular in-service at the beginning of the year for all these new doctors that's arriving to help orientate them both to the practicalities of rural health care and to some key clinical topics. But implementation has always been challenging. So over the different years, we've tried different things, and to cut a long story short, we've never actually managed to get something off the ground. There's several reasons for this. The first is, of course, that we need to cover a wide range of different things. So we worked out that's about 30 hours contact sessions we were looking at. So it was about a 5-day program we were hoping to set up. But of course, the doctors arrive and they're actually a key part of service delivery. Your district hospitals are isolated, scattered over a huge area, and you literally have, 2 ComServes here, 2 ComServes there, 2 ComServes there, and they simply cannot spare these doctors for a 5-day course at the beginning of the year. And of course, it gets expensive for you now have to transport everybody to a venue where you have to feed them and accommodate them and pay for conferencing fees. And even if your facilitators are all doing it for free, which is what we were looking at, it is actually becomes a very expensive thing that you then have to get funding for every single year. And then, of course, came COVID-19, and with it came Zoom. And suddenly everything changed. We suddenly had a setup where every doctor has got some sort of access to online training, whether it be Zoom sessions or at least looking at stuff on YouTube. And suddenly all of these challenges around logistics became a non-issue. So what did it look like? We called it Rural Onboarding. That's a new cool name for in-servicing, helping people, that little flight talk you get before you take off. And what we decided at that stage is that we'll do it over a 6 weeks program. So we actually started in February of this year and we went till about mid-March. And our target group was new clinicians. So although we've always had community service officers in mind, we were quite happy for any new clinician joining the Eastern Cape Rural Health Facility to join. And we wanted it to be for everybody, but because it was new and we were sort of designing it from scratch, our materials in the beginning this year were still very orientated towards doctors and clinical associates. But we also had some rehab staff joining some of the sessions that were relevant to them. And the idea would be to eventually have a program where you have your core topics that's useful for all professions, and then you have all your specific streams for all the different types of clinicians joining facilities. And what we did was that we made the course obviously fully online, so there was no contact sessions at all, and it consisted of 2 main parts. The one was a Zoom webinars that happened every week, 1 or 2 webinars, and then we sent out these resource packs via email every week, and I'll show you what that looks like. So we decided this all in January and sent out some WhatsApps and got something up and going. We literally created the course as we were running up. And we created like an online Google form, and we were very happy anybody could join. We didn't have any criteria of who could join. And so we therefore also, for example, had mentors already in the field, been around in rural health for many years, but who wanted to have access to that kind of contact. And our communication for the course was mainly through email and Telegram groups. Remember, there was all that stuff around WhatsApp, and so we thought, let's try out Telegram. So we created a Telegram group, which certainly has its advantages, but is not yet as broadly accessible as WhatsApp. And we had 60 clinicians that actually joined up officially onto the Rural Onboarding Program. And it's interesting to see what a wide range. So 48 of those were doctors, but note that only 16 of those was community service officers. But we also had interns that joined, we had medical officers, we had registrars, we even had specialists, most of them either wanting to update themselves on some of the topics, or some of them actually really interested in overseeing some of this mentoring to also look at access to materials, etc. We had some private GPs, we had a retired GP who wanted to update, and we had a clinical manager that joined as well, also to look in terms of accessing materials for his doctors at his hospital. We had 2 clinical associates that joined up, 6 nurses, and 4 occupational therapists, so a real mixed bag of different people. Important to note is that although they were officially on the program and they officially got all the emails every week, the Zoom webinars were open and we advertised it open. So there were a lot of people who attended the Zoom online sessions that was not necessarily on the database for the weekly emails. What is also interesting is that we obviously put it out on the Eastern Cape, but we put it on the RuDASA page and went on Facebook. And so we did not only have people from the Eastern Cape that joined, so we had 46 from the Eastern Cape, but we had Western Cape, Gauteng, KZN, Northwest, Northern Cape. We had somebody from Botswana that found us. He was actually a mentor and was looking at a way to look at the program to be able to replicate it in his own area. And we had a South African doctor in Germany and homesick and wanting to stay up to date. And that already gave us a glimpse that, of course, when you do something like this, your ability for people to access it becomes almost international. So a little bit more background on the actual Zoom webinars. So, we already had, WUSU had started weekly family medicine tutorials run through Dr. Dylan Gibson. And so we thought, well, we'll use those, still go ongoing, and we'll add in some extra sessions that we thought were specifically relevant to new doctors. And all of these were uploaded to YouTube. So if you missed a session, it didn't matter. You could watch it at any time. RHAP provided us with the Zoom account to be able to do this, and WUSU has also got their own Zoom account that Dylan's been using. The slot was interesting, trying to see what time of the day. Working hours is not great unless you do it at 8 to 9 as part of a normal CPD session at the hospital. So they usually have to be the evenings. Some people prepare 5, some prepare 6. So we did them at different times. And if you missed a session, you could catch up on YouTube. We didn't use CPDs at this point, but that's definitely, we'd like to do that in the future. Community service officers don't need it, so we didn't make it a priority when we started. And we had 14 Zoom webinars that happened during this time. It was uploaded to a YouTube list. And we had roughly about 41 people attended per Zoom session. So at least 22 was our smallest session, right up to 86 when we were covering some obstetrics. And 11 of those are now part of our YouTube list. And at the end of April, we had an average of 59 views. So this would probably have been in addition to people who'd actually been to the actual session, but people had gone and watched it afterwards. And what's lovely about it is once it's on the website, obviously, once it's on YouTube, any new clinician at any time can go and watch these. So it keeps on being available, and it's still available at the moment for new doctors coming. So here's some of our topics. A lot of it was dependent on who was around, covering the kinds of things we thought were relevant, and very much Eastern Cape based. So we had some bit of HR stuff that Dr. Ben Gaunt helped get us started on that, but we had from orthopedics with Prof. Gibson, we had infectious disease stuff with Dr. Stead, we had an obstetrician doing, Dr. Mondonde doing some amazing stuff, as well as Prof. Hofmeyer around making obstetrics safer. We had things on neonatal care, and then some soft topics, preventing burnout, teamwork, and patient-centered care. So it was a whole range of different things happening over those weeks, and those were all uploaded. On the right, this is the views on YouTube we had by the end of April, and I just checked now at the end of August, and you can see most of the views of people were going to watch it happen in that first month after the course ended, because we were sending out the links and promoting it. But you can see some of the topics, like HIV is very popular, Spinal anesthesia is very popular. Those links are out there now, and people are still using it to watch. So then we had the resource packs, and I'm not going to go through these in details, but we sort of had a topic. So week 1 was infectious diseases, and we sent out stuff on HIV and TB. Week 2, we looked at maternal health and occupational health. Week 3, we did some advocacy stuff and chronic disease. Week 4, we looked at child health, and then we did a soft topic, thriving in rural health care. In week 5, we went to orthopedic surgery, emergency medicine, anesthetics. And week 6, we looked at patient-centered care and some of those key programs. And this is just an example of what that would look like. In week 4, for example, when we were doing neonatal and child health, we would have a whole lot of links that we would send out, as well as PDFs where appropriate. So including IMCI chart booklets, ETATS participant manuals. Limpopo has got an amazing neonatal essential newborn care package in terms of training. The Union's Desk Guide for Diagnosing and Managing of TB in Children, Severe Acute Malnutrition. So a whole hodgepodge of stuff would be sent in an email. Then, of course, we wanted to evaluate how we've done. And the challenges with online webinars and distance learning is it's very difficult to judge exactly how effective it is. And certainly we haven't been able to measure impact. We weren't quite organized enough. We certainly had an amazing response from specialists, mentors, and experts who were all keen to contribute. Everybody wanted to be part of this. And the comments in the lecture themselves were very positive. So we got a lot of positive feedback on WhatsApp and in the lectures saying, this is great, thank you very much, etc. So we did then try to do a more formal evaluation, created an online evaluation form, but we only had 8 responses. People do not like filling in surveys. Out of our 60 people who were on our list. And of that, there was 5 doctors that replied, 2 ComServe doctors and 1 clinical associate. And we didn't really have enough people to reply to really give us an idea of the scope. It looks like 90% at least confirmed that they'd completed at least some of the topics. The worry is they sign up, but they don't actually do anything. But all 7 of them considered that all or most of the topics very useful to practice, and they all requested the program to be rolled out nationally from next year. So the strengths in this program is that it's widely accessible to any level clinician. Zoom is now everywhere, and most rural clinicians seem to have some access to connectivity. And these days, if NGOs want to help, all they need to do is provide people with some data. All the other tech is sort of in place now. People can watch on their phones or their tablets, or I don't need anything fancy to communicate with them. The structured weekly tasks does help to focus on key learning areas, and it structures the work over time, which I think makes it much more likely that they'll remember things than that intense 5-week maths learning that one does. So interleaving a very useful way of teaching young doctors. But it also means that they can take where they need to. So if they this week in working in obstetrics and maternity, and they want to particularly watch those things, they can tailor make their learning depending on what they are doing. It's free, which is great. And it's available all through the year, so it's not going to be something that you just, if you miss the boat, you've missed it if you started a quarter late. Great, so where do we want to take this next? So, of course, we'd like to professionalize this. So, for example, we would love all the material to be available on a website page. So instead of sending them these weekly email packs, that you've got a nice portal where you can just simply go to when you're looking for something specific. It's been not so easy to create that through RuDASA. I'm currently at WUSU, and I'm busy negotiating to see if we can put together at the WUSU Family Medicine and Rural Health a page specifically for this purpose. Of course, CPD points we would love to organize. So the way that will work is you will have all your material, and there'll probably be MCQs, and it needs to be automated. That can be done at the end of watching a session, and then if you get a certain amount right, then you get your CPD points. We'd also love to make it much wider, so that your nurses, your physios, your rehab, your clinical associates, everybody should be able to engage, and we can have topics that is cut across the board, and then we can have those that are more specific to the different fields. We also need ongoing quality assurance to obviously ensure that everything stays up to date. At the moment, I'm quite happy to do that as my role with Walter SisuluUniversity. So that we ensure that there's quality information and that we take things off if guidelines change. And it'd be lovely to actually measure impact. So I need some help with that in terms of methodology to evaluate how people are finding it, how we can adapt the course, but also how much it's impacting and changing clinical care on the ground. What we'd love to do is eventually have it linked to actual specific mentors. So now virtually one could do that. So you have a set of designated mentors anywhere in the country really, but preferably provincially based. And any mentee that signs up gets allocated somebody, and then one would have to look at how we create that mentoring structure. And we'd love to do it nationally, which we'll talk about at the RuDASA in Ndaba. So at the Ndaba, we will be discussing specifically, we would love to put together a national open access orientation program for any new clinician joining a rural facility. And it looks like it will also be used by existing rural clinicians who is trying to update and upgrade their skills. We would like to link new doctors coming in to designated mentors for a more personalized support. And we would like to link content to specific outcomes. So, for example, maybe somebody wants to do the HIV diploma, then part of it can be a little program that helps you to prepare or join a group to get ready for the diploma in HIV medicine. And there's lots of great diplomas that adds benefit to rural health, and one can use this portal as a way to create that support structure. And then just lastly, a quick thank you to all our amazing group of Eastern Cape facilitators that made this possible. They all gave their time for free, did the effort to actually prepare presentations. And we had some very esteemed experts that was helping us out. RHIP for providing the Zoom link, that's an expensive expense. Dr. Dylan Gibson for the WUSU tutorials and helping us and allowing us to access all of those. And then RuDASA and Steph for all the support in terms of advertising and some of the practical logistics of the training. And we would love to interact with you at the RuDASA in Ndaba about taking this up to the next level.